for the sake of the discussion, so the patient has multiple bony metastases, but he has no pain. He's clearly not taking a narcotic. This becomes a little bit of a discussion point, I think, that we talk about all the time. What is the definition of minimally symptomatic, symptomatic? I think, Dan, comment, if you will, about, I think people mistakenly think it's just about pain.
No, I think it's about what you're taking for the pain at the same time. So narcotic analgesia is what I usually use as the cut point. If somebody's requiring narcotics to control their pain, that's not minimal pain. If it's something like a non-steroidal, that I would consider to be minimal pain. So I think it's a subtle distinction, but nonetheless, narcotics is the determining point.
And I think what he's saying is exactly right. In fact, when you were looking at the clinical trials, most of them required, with the exception of the immunotherapy, some degree of symptomatology for approval on many levels. And most of that, for entry, the easy way was to require narcotics and fill out pain scores. But we all know there's lots of different ways you can become symptomatic.
Neal, you've looked at this quite a bit in terms of, again, I mean, classically we've always just talked about pain, but clearly there are people, especially men, who are quite stoic. They oftentimes don't give us the whole answer. Sometimes we have to depend upon their primary caregivers, family members. That seems to also be becoming more and more important these days.
Yeah, I think you're raising an incredibly important point. I find the concept of, or the definition of symptomatic is very murky and vague. And more, I think that we're changing very significantly as clinicians as to what this means. And I think you're alluding to the fact that there are certain generational differences about how we complain about pain. There's clearly phenotypic differences. Men historically, not everywhere, there's some concern that to complain is to not be manly, and it's, men don't cry, and sort of that concept. There's the concept that if a male patient might complain, he might be disappointing his physician for fear of that. There could be a concern that maybe there's a complaint of any sort of discomfort, whether it's pain or not. Maybe it's an inability to hit a tennis ball or walk up the stairs or get in and out of a car, might be perceived that my disease is progressing and therefore my clinician, medical oncologist, urologist, radiation oncologist is going to offer me another therapy, and that scares me because I don't know what that's going to be. Or I don't want to burden my family, so I'm not going to tell my wife or my children. And I think we've all had the experience that when we ask some of these patients, when we're sitting knee to knee to them in a clinic, and we say, are you having any discomfort? Are you having any pain? We usually say pain. We're very binary about it. We probably should be much more interrogative about other signs of symptoms. Are you moving around? Are you playing golf anymore? Do you drive your car? Do you take out the garbage? How are you sleeping? Because are you getting up in the middle of the night and wolfing down NSAIDs or COX-2 inhibitors? But when you ask that question to your patient and he nods his head, oh no, I'm not having any discomfort. How many of us have had the wife sitting next to him go, oh my gosh, he's miserable? And I see this all the time. And I think one of the constraints is that we're all very busy seeing more patients, and we need to take the time to interrogate that of our patients. Even culturally, certain parts of the world, there are certain cultures that just won't complain, and then there are other cultures that are much more aggressive about their complaining. We see that in the United States, different regions of the country. So I think there's a lot of new data that's coming out that would help us, not just the physicians, but our nurses, who oftentimes spend more time with patients regarding their symptomatology, so that we could do a better job. And this becomes important because thanks to the work that Mike's done, and Dave and Dan and all the trials that they've led, we have these therapeutic options. And if we're not asking, well, then we can't think about the right therapy to give.
As Mike had alluded to earlier, is that we have these windows, and the fact that many of these metastatic castration-resistant prostate cancer patients, because we know bony metastasis is so prevalent, there does seem to be this element of this that symptomatic is defined as the use of opiates. But like Dan, is what you said, is that it depends upon what they're using, how much they're using. So, Dave, can you help us clarify this? Because again, symptomatic isn't not necessarily just opiates. Correct?
No, and I think it's not. In the population we're dealing with, they're not going to say, you know, my leg hurts and I've got a metastasis there. It's a little more complicated than that. So I have patients that will not take anything more than Tylenol. And if their dosage is going up, and I know they've got bone mets, there are usually other indicators like the alk phos going up a bit, maybe not even to the abnormal range, where I'm thinking they have an abnormal bone milieu from their prostate cancer, and I'm thinking they're candidates for bone-targeted agents, specifically radium, but also me getting on board with a calcium and vitamin D and maybe giving them an anti-resorptive agent. So I don't think they have to be necessarily taking opioids at all to be symptomatic. I think it can be much more subtle than that. And this is difficult because it's an area of clinical judgment where when you're sequentially seeing the patient, I think that's almost more valuable than anything. Following the progress of their disease is very important.
Hey, Ro, can I make one small comment just to add on to what Dr. Quinn is saying? Is what's interesting to me about radium is, and we're talking about pain and opioids or non-opioids, but I never think about really giving this as a pain alleviating drug. I give radium for survival prolongation first and foremost. About a third to 40% of my patients will get some pain benefit. I don't give it for pain palliation. I give it for survival benefit, which I think is what you clearly showed in the revised CRPC guidelines, thanks to Mike Cookson. That's it's really its primary indication, at least in my mind.
Yeah. No, I think that's right. I think that's the problem, because we've clearly used other radiopharmaceuticals in the past as palliative agents. Like we all know that this drug is a therapeutic agent. It has a survival benefit. As Dan said, that survival benefit is with 6 weeks, or six injections, and should not be used as a palliative agent. But again, I think, like you said earlier, this concept of getting into that window with the use of radium.
Well, and one of the things that we all know, but it should be pointed out, is that it can be used pre or post-dose of Taxol. We talked earlier, it's hard to combine those. There is a lot less tox. The older agents that we had pretty much would wipe out the bone marrow, eliminate chemotherapy as an option for many patients. That's not the case with radium, but I think it can be given pre or post depending on the situation, and because the marrow toxicity is so much less, it still opens up lots of other opportunities.
And also from that standpoint, there's no difference in the rates of neutropenic fevers in those patients who receive docetaxel either pre or post radium. And there may be a little bit of a diminution in the neutrophil counts after chemotherapy, but that doesn't seem to be something that's significant, nor that has impact on patient care.
And I think something that you mentioned, David, is, which I think as urologists we don't necessarily measure enough, is really what their alkaline phosphatase is doing pre as well as post therapy.